is probably one of the less emphasized areas in instability, because Bankart took a lot of the attention, and it's over the years the evolution of Bankart told us, and we evaluated the failures when we came to know what was the problem. But when you're dealing with bone loss and instability, we need to look into what is the agenda of this talk, is what is the critical size of bone loss that will compel me to change my procedure from Bankart to something else. Is the bone loss worse on the glenoid side, or is it worse on the Hill-Sachs side? Which one is the more critical bone loss? Whether we can evaluate them accurately, understanding the glenoid tract concept, and lastly, can we accurately restore? So none of us can emphatically tell that we can actually accurately restore, but we are coming very close to that situation there. This is the paper that probably spoiled everything. One was Jodibes' paper suggesting that massive failures in rugby players, and then Pascal came out with his ICE score and found out that there was a 31% recurrence in the young patients who had a bone loss. The importance of that 5 mm fragment, which to the naked eye seems minuscule, it can be guessed on this, where you can see that the arc of stability is significantly compromised because you've just changed the trough into a flat area there. So perhaps those of you who rely on MRIs for shoulder dislocation patients should switch over to doing a CT scan, because that is probably the only investigation that will pick up a bone loss, especially on the glenoid side, probably if you're doing a subtracted study. There are a lot of complicated, contorted ways to measure glenoid bone loss, and there will never ever be an agreement between us surgeons as such. What we use is a very simplified technique where we measure the AP diameters on the normal side versus the affected side. Now, unless the surgeon knows the unaffected diameter, it is impossible to evaluate the percentage bone loss. And when we talk about percentage, that 15% bone loss is my threshold for Latarjet. Unless we evaluate the normal side, there is no way the radiologist can comment. And we try not to rely on radiologists to make that decision on our behalf. We would like to do that ourselves, because we are responsible for making that decision for the patient. Now, a lot of us have this impression that the open Latarjet is probably the answer to global warming. But we must understand that the open Latarjet itself is not an easy procedure, even in my hands. It is a rather complicated procedure. It requires a lot of focus, determination, tenacity, and is as complicated as an Arthro Latarjet, really speaking. So I don't get this concept that Latarjet open is an easier answer. Regional, because if you are French, then you are probably going to do all your instabilities with a Latarjet, and then you can't use one brush to paint the whole town red. I think we should resort to a more horses for courses policy and decide objectively that a said patient has 20% bone loss, I would do Latarjet, and I would not do Latarjet for anybody who doesn't have 20% bone loss. It can be less precise, it is non-anatomical, but between this hall, what Latarjets you and me and others do, we are all doing a different technique. It is not like a Ponseti technique where everybody is doing the same Ponseti technique for clubfoot. It is not like DHS for fracture neck femur where everybody is doing pretty much the same technique. So each of our Latarjets are different, so I don't think we can compare each other. Irrespective of which Latarjet you do, I strongly recommend that you must CT scan him. The X-rays are completely inept at evaluating your post-op Latarjets, whether the graft is healed, whether it is placed correctly, or whether it's healing at all. So you must do a CT scan to assess the position of the graft, the direction of the screws, and to ensure that there is no metal failure or affecting the suprascapular nerve. And the Arthro Latarjet is taking this beyond, pushing the envelope to the far extreme, and if you're bold enough, you have enough testicles, then feel free to do the Arthro Latarjet. But I don't think there's a heaven and earth difference between Arthro and the open Latarjet. It's just a fantastic technique of pushing the envelope and doing a very precise Arthro Latarjet, because your field is 20 times magnified. You can't do the same errors that will happen in the open Latarjet. And perhaps as Gilles Walsh, who's the biggest proponent of the open Latarjet, said that the future is Arthro Latarjet, all the surgeons are going to go into Arthro Latarjet. And that tells you the precise location, the precise union, and the flush sitting of the graft along the arc of the glenoid. Irrespective of who is doing the Latarjet, it could be Lafosse, it could be you, it could be me. osteolysis is inevitable and we have to reconcile to the fact that osteo is gone. Unless you do your scans a year later or 6 months later, we will never be able to pick up, and very few of us actually follow up these patients. So you must do them. Moving quickly on to the bone loss on the humeral side, the Hill-Sachs is not a sign of recurrence. It can happen in the first episode. It correlates with the velocity of trauma. You need to have your radiologist measure the amount of Hill-Sachs, and then you can decide whether you wish to do a remplissage or not. Just quickly finishing off with some evidence-based medicine, because you need to understand that the Latarjet can be better than a Bankart and a remplissage, especially in the revision situation, which was a group B. The Latarjet had a 8% recurrence and remplissage had a 14% recurrence. So be careful about that. Now, if this is Laurent Lafort's paper treating Hill-Sachs lesions with a Latarjet, and he was able to increase the glenoid arc by 14%. It was actually 122%, and then slowly it gets osteolyzed. So a Latarjet itself can solve the Hill-Sachs problem. When you have a different type of a wedge Hill-Sachs, then it's probably prudent to do a bone graft rather than a remplissage on these patients. So this is a study of the top European surgeons who are doing Arthro-Latarjet, 1555 patients, that's a whole lot big sample size, and look at their complication rates, which are 0.2, 0.6, 0.4, 1. But the conclusion of the article was that the difficulty of the procedure should not be underestimated. All these chaps are those who do about 80 to 100 Arthro-Latarjets a year. So the Arthro-Latarjet is not full of complications, really speaking, but it's our perception towards the Arthro-Latarjet. Don't take the open Latarjet lightly. There are a huge number of complications published in literature. This is just one of the papers where 30% complications with the open Latarjet, and we've seen that, really speaking. So please don't take it lightly. You need to have a lot of diligence and surgical skill doing the open Latarjet. In terms of Bankart versus Latarjet in patients with 15% glenoid loss, this is a very nice paper from Jeon in South Korea, and look at the recurrence rates, 22.9% in Bankart, 6.5%, but the external rotation loss was more in the Bankart group than the Latarjet group. So the perception that open surgery, open Latarjet will lead to a loss of residual ER is a myth that has to be exploded. Fantastic paper, randomized open versus arthroscopic Latarjet. Look at the recurrence rates, pretty much similar recurrence revision. The only thing is the complications were far more, 13.8% in the open group. The interesting thing was apprehension test was positive in the Arthro-Latarjet group, and there's a reason for that, because the group that did these Arthro-Latarjets were not repairing the labrum, so that's expected. So, to the conclusion, the range of movement after Latarjet is no different than Bankart. If at all, it must be better than a Bankart. Arthritis of the Bankart-Latarjet are similar. Return to sports is much more likely with a Latarjet as opposed to a Bankart. So in conclusion, data, biomechanics and clinical favor the Latarjet. Young competitive epileptic patients, late presenters, bone loss, I would always do a Latarjet on these patients. You have to decide what's your threshold limit for Latarjet and check which technique you're using to quantify the bone loss. Thank you very much.